In October of 2004, I made my first trip to Africa, and I was pretty excited. It was Africa. I was a little bit scared, and I went there to work for 2.5 months at a hospital in the north of Uganda. It's a 500-bed hospital that serves the community, the region, providing low-cost care or free care, and it's somewhat unique in some of the services it supplies. Within the hospital compound itself, it's a walled compound, live not only the patients, but the staff and their family. For security reasons, it wasn't safe to live outside the hospital, and also the caregivers of the patients. In Africa, it's typical that each patient will have their own caregiver who provides their food, their bedding, helps them to the bathroom, and does a lot of the things that we might think a nurse would do at home. Those caregivers are usually women, and they often have 1 or 2 children with them, so it's quite a crowded, exciting place, and it made me feel at once that I was in a very different atmosphere and that I was in Africa. The next day, I made rounds at the hospital for the first time, and again, as I saw the surgery ward, I realized all the differences I would be encountering in my 2.5-month stay. One of the big differences was the patients themselves. The patients had problems that we don't see in Canada. There were patients with leprosy, a man who had been bitten by a crocodile, and there were also problems that we would commonly see, but that are treated differently in Canada. There were lots of people in traction, there were open infections, there were non-healing wounds. I also learned that in Africa, 500-bed hospital doesn't mean 500 patients, because extra patients are just put on the floor to lie on mats or sit on benches to get their treatment. I spent the next week at the hospital trying to learn where I could fit in, what I could provide. And as I got to know the nurses and see the patients and see the system, I realized there was one group of patients who didn't seem to get the quality of surgical care that I thought they should. And that group was the burn patients. Now, in Africa, most burns occur in children under the age of 5. And it's probably because they use open fires for cooking and for heating. There's a lot of children, and the children are much less supervised than they would be in Canada, and this leads to a lot more accidents. And unlike Canada, burn care is delivered at the local hospital. Here in Canada, burn care is delivered in specialized units with specialized people who know exactly what they're doing. And I didn't have a lot of experience in treating burns, certainly not serious burns. And I remember one particular patient, a little boy I saw, who the first time I saw him, his dressings had been taken down, and you could see that 30 to 40% of his body had been burned. He had burns on his arms and his legs, on the side of his body, and even though it had been 3 or 4 months in hospital, he still wasn't healed, and he had started to develop a contracture of his leg, and he had had one attempt at skin grafting, but it hadn't worked particularly well. And there were lots of other children in hospital like him. I think at that time, there were perhaps 15 patients with burns. So I tried to look within the hospital to figure out why these kids weren't getting the kind of care that I thought they should. And I looked at what were the barriers to care. Certainly one of the big barriers was cost. The dressings that you need for these burns can cost hundreds of dollars each day, and that is money this hospital certainly didn't have. And for dressings, they came up with a fairly ingenious solution. They had a group of women who would spend all day cutting up rolls of gauze dressings, folding them into bandages. Some of those bandages would be soaked in Vaseline and sterilized, and others would be soaked in a mixture of paraffin and honey and sterilized, and these were used for the dressings. And it worked quite well, it was quite cheap, kept the burns clean. But they still needed to have surgery, and it wasn't being done. Some of the barriers to that were the surgical service itself. There were a lot of patients, and these kids weren't seen as a priority. The doctors had other issues to focus on. They didn't have enough anesthetists to put patients to sleep. These kids were often scheduled at the end of the day, and if the day was running late, they would just be put off to another day. Malaria is very common in these countries, and we would check the kids for malaria before their surgery, and probably 1 in 5 or 1 in 6 kids would have malaria the day of their surgery. Surgery would have to be canceled and rescheduled. In trying to look at the materials they had, I decided I'd look through the storeroom of the operating room where they kept all their medical supplies. And in that storeroom, they had one half that was quite neatly organized. These were the supplies that the hospital bought for itself. They're gauze, bandages, suture. The other half of the storeroom was filled with cardboard boxes, not unlike the cardboard box of supplies that I had brought. And as I opened up the boxes, they were filled with a variety of things, some of it useful, some of it totally useless, but none of it really being utilized, and it was slowly turning to garbage within that storage room. And the trouble was that people would bring things, much like I had as a visitor to the hospital, but the people they were donating these supplies to didn't know how to use it, or didn't have time to unpack it and get it into use, so it would just lay there and eventually turn into waste. Also within the storeroom, I found one piece of equipment that was quite different. It was a box that contained an electric, it's called an electric dermatome, it's for taking skin grafts. Now this is extremely useful for these burn kids. It takes a great skin graft, it's going to help in healing, it's very easy to use, and I couldn't understand why when they had such a great piece of equipment they weren't using it. So I asked around, I spoke to the doctors and I spoke to the nurses, and it became clear to me that the issue had been that although someone had donated this to them, they didn't show them how to use it. And since they didn't know how to use it, they felt uncomfortable trying to learn on their own, or they didn't have enough time, and eventually it got shoved aside and was never used. They were using a system of taking grafts by hand, and although that system works well, it demands a sharp blade, and again, blades are expensive, so they couldn't afford a new one each time, and the same blade would be used maybe 15 or 20 times instead of once. And although it was sterilized after each use, so infection's not an issue, if it's dull, it can't cut to take a skin graft. It leads to a graft that doesn't work as well, doesn't heal as well. And when it fails, it discourages both the patients from having further grafts and the doctors from wanting to do other grafts. I also, over the week or two, remember seeing another patient. This was a little boy who had a severe burn the year before. He, in fact, was in a house that had been set fire by members of the Lord's Resistance Army who were active in the area at the time. It had burnt down his home and severely burned him. When he came to hospital, they didn't think he would survive. But despite all odds, he did survive, and they were very pleased with that. But because his treatment had focused on his survival fairly narrowly, no one had thought to treat his hand, and he had come in with a severe hand contracture. And his hand, in fact, I can't even demonstrate it. His wrist was pulled back, and his fingers were pulled back beyond what I can physically do to mine, and it made his hand totally non-functional. And it's something that if he had been treated with skin grafts or treated with a splint, it might have been prevented, but they didn't have the knowledge or perhaps the time to focus on that. So over the next few months, or next few weeks, I guess, about 6 more weeks of my time at the project, I spent some time trying to teach the staff how to use the really cool electric dermatome, and in turn they taught me how to use the not as cool but very useful hand skin graft system, because it's not something I'd ever used in Canada. I tried to teach them what I knew about burns, and I tried to learn more about burns so I'd have more to teach them. I don't treat burns in Canada, and so I was busy studying my textbooks and looking on the internet and trying to keep 1 or 2 steps ahead of them. Sometimes it seemed to work. Other times they didn't seem as interested as I was, and I would be discouraged if I spent a day trying to teach something and seeing over the next week that it wasn't being incorporated. Now, I've been back in that project 5 or 6 times over the past 10 years, and I've seen gradual improvement. The hospital built a burn unit, and so now 10 or 12 patients can be treated in the same room, and that leads to more consistent nursing care, better dressing changes, a better awareness of what their needs are. I worked with the physiotherapists a little bit, and they're more focused now on working on preventing contractures. I've treated children over that period where instead of a 6-month course in hospital, we got it down to maybe a 6-week course in hospital with early burns and grafting. But I've also had to accept that it's not perfect. Things could be better, and I sometimes feel I've failed a bit when I see that things aren't improving as fast as I think they should. And so that's caused me to reflect on what I've learned about humanitarian care. I've had the same experience on other projects, so I think it's a fairly universal fact. I'll start off with the value of donation of materials. People very kindly collect things from their home hospital and send them off to Africa, sometimes without thinking of how that material will be used. And I've gradually realized that if it's something you can't use at home, perhaps they can't use it in Africa either. You have to think, is it something they need, not just something extra that you have to give? And once things are given, they have to be unpacked and put away. And if you're the donor who's brought it, you need to do it, or you need to set up some system that it happens when it arrives, or else it's just going to sit there and not get used. The other thing I learned is even a great donation, like this electric dermatome for taking skin grafts, is useless unless someone can show them how the technology works. So if it's something new to the system and they've never used it, then they need someone to explain it to them once and twice and more than twice, to leave written instructions to show people how to fix it, which is the other part of the issue, that any equipment of a technological bent needs to have with it a follow-up repair program. If not, within a year or two, it's going to be broken and useless. So more and more programs have looked at sending technicians on a regular basis to projects to keep track of donated equipment and repair it as needed. And I think the last lesson I learned, and I'm still learning, is that you need a lot of humility when you go out to work in a setting that's not your own, in a country that's not your own. And I think when you first go, and this may be truer of surgeons than other people, but you have an underlying arrogance, which you don't say, but you mentally think, I know a lot. In fact, I know more than you do, and I can show you how you can do things better. And although the reality is I may know more about Canadian surgery, I don't necessarily know more about African surgery, and I certainly don't know more about the setting that they're working in. And so as much as I'm there to help and to teach, I'm there to learn from them, learn what works, learn what doesn't work. I learned that you need to make progress in very tiny steps. It's not going to happen in a big picture. It's going to happen bit by bit. And accept that the small step is worth it, because the small step brings to another small step, and eventually you've gone several steps ahead. I'd like to end with a quote that I heard long before I got into any aid work, but I still think of it sometimes, and it still reminds me of how I try to approach some of these projects. And it's a quote by Edward Everett Hale, who was an American in the 1800s. He was a minister and an author. And the quote is, probably praised a little bit, I am only one, but still I am one. I cannot do everything, but I can do something. And I will not let the everything I cannot do stop me from doing the something I can do. And it's a reminder to me that when I look at a big problem, I don't have to find the final solution, and I can't use that as an excuse to say, this problem's too big, I can't tackle it. It's for someone else to discover the answer. There's not the answer. There are little steps that are small answers.